people already had a chance to see it. So I am recording this session, and so if you're shy, turn off your video. If you're not shy, make sure you turn it back on. And I'll switch my camera over to the demonstration mode. All right, so I've set up the camera a little bit differently, so hopefully you'll be able to see what my hands are doing as well as what's happening on a close-up. And I've got this artificial skin set up right here, and so I'll take off my tendon when I'm finished doing the suturing of the tendon to my incision that I've got underneath it. So anyway, the first demonstration that I'm going to do is the locking loop pattern for tendon ruptures. And so if you've got either a ruptured tendon or you've had to transect a tendon, say you're doing a femoral head and neck excision, or you're doing a lateral elbow condylar fracture, and you've had to transect the triceps tendon, then this is how you would repair it. So if you were to just do a simple continuous suture pattern, what happens is that because the fibers are linear, when you pass the suture into the tendon, it's going to have a tendency to pull out. And so we do a pattern called a locking loop, which is going to provide better tension or combat tension in the tendon. So the way that we do this is the first pass that we're going to make is we're going to take our needle, we're going to pass it through the body of the tendon, we're going to have it exit through the cut end of the tendon like that. Can you guys, is that in focus for you? There we go. So through the cut end of the tendon. And then we're going to go in on the other side of the tendon, exactly the same place that we came out. So I'm just going to pull this through a little bit. Getting a bit of tissue drag here. And we'll just get that out of the way. And then we're going to go in the other side of the tendon exactly where we came out. So we want to match that perfectly. So going in to the cut surface of the tendon there. And we're going to come out about the same distance that we went in. And we'll pull that tight as well. And it's already starting to line up the two tendon ends. Now the next bite that we're going to take, we're going to go perpendicular to the other two and split the thickness of the tendon. Try to keep my head out of the way. And come out on the other side. And you see how it makes a really nice loop. And when you pull that loop tight, it's going to constrict some of those fibers and keep it from pulling out. Then we're going to come back into the tendon and come out on the cut surface. I'll go in a little bit deeper, come out on the cut surface and try to go through kind of in the middle of the cut surface of the tendon. Pull that tight. That's going to make us another loop. Then we're going to go in exactly where we came out on the other tendon and try to go about the same distance here. And then we'll pull that tight. And then we'll come across like this again, and you can see that I've made, when I pull this tight, I will have made 4 loops. And each of those loops is grabbing the fibers of the tendon and keeping them from pulling out. All right, so now we've completed that pattern. And so you can see that it's very, very strong. I'm pulling quite hard on that, and it's not coming out. So that's called a locking loop suture pattern. And then if we wanted to make it into what's called a modified Kessler, with a modified Kessler, what we're doing is we're suturing, just doing a simple continuous suture pattern of the peritoneum. So, and what that's going to do, it's not going to add a lot of strength. Sorry, that's pulling through. It's not going to add a lot of strength. Let me just mute everybody again. Manish, can you please mute your microphone? So we're just going to do a simple continuous suture pattern around the... Everybody please make sure. Manish, can you please make sure that you are muted? Where is he? I don't know why I can't mute. So I'm muting everybody again, but for some reason, Manish is not allowing me to mute his microphone. But if you come on again, I'm going to have to throw you out. Okay. All right. So we're just going to do a simple continuous suture pattern all the way around the outside of the tendon in the peritoneum, and that's going to make the tendon glide more easily. So we'll go 360 degrees around this tendon. And so that converts it from a locking loop suture pattern to, and it's just pulling through, sorry about that, but that's going to make it into a modified Kessler. So any questions about that? Let me just, and there's a video of that Piyush has given me on the chat. Piyush, you want to put that in, instead of in private, share it with everybody, and so everybody can copy a link to that. So anyway, that's how we repair tendons, locking loop pattern and modified Kessler. So I'll go ahead and cut this out, and you can see then my incision that I've got underneath from the last time. And sorry that I'm using this same suture pad. These are really expensive, and so I'm going to try to get one more use out of it. I'll zoom out a little bit so we can get the whole incision in there. Can you guys see that whole incision? I'll just move this out of the way so I can see. All right, so now I'm going to show you how to do a slip knot. So I'm just going to, when I do knots with suture material, I never do a surgeon's knot. So a surgeon's knot, I'll show you how you would do it, but I don't like to use them because I don't find them particularly precise, and I also don't find them very secure. So this would be a surgeon's knot. We've done 2 loops. We pull it down like that. So that's a surgeon's knot, but my preference is to do a slip knot. And the way we do a slip knot is that we leave our first knot loose, second knot loose, and then what we do is we just pull on the long end of the suture, and that's going to convert it into a slip. And then all we do is pull on the long end. We leave the short end loose, and that can get quite tight or quite snug. And then you pull them apart to lock it. And then you do 3 or 4 throws on top of that. Piyush, I think that your microphone wasn't muted. All right, so, and then you cut that. And so that's how I like to do my suturing. So no surgeon's knots, I prefer to do slip knots. So I'll cut that out. Now you wouldn't use slip knots in the skin, or at least you wouldn't pull them tight in the skin because you don't want to constrict that tissue too much. All right, so now if I were to suture this incision here, and you want to bury the knot, so this is an intradermal suture pattern, your first bite has to be deep, and then you want it to come out superficially. So when you come out superficially, you want to come out right at the corner of the skin edge. And then on the other side, we're going to go in superficially, right at the skin edge, just like we did, just like we came out, and come out deep. What that means is that all of our ends are going to be deep. And then we'll pull this down. And then when we tie our knot, I'm going to use a slip knot. Okay, so leaving my ends loose, and then I'm going to just pull in one end. That converted, sorry, into a granny. So pull that tight, and then we add our 3 throws on top of it. Whoever's in art, Rebecca, please mute your microphone. Okay, so we put all of our throws on there, and then you can see that our knot is not very well buried because I'm pulling on it. Now, when we take our first bite, we want to go from deep to superficial. So deep to superficial, and that's going to be the final step in burying our knot. So coming out right at the corner of the skin edge. And then when we pull that down, it should pull that knot underneath and bury it. And then when we go across, you want to go back in exactly where you came out. So superficial to deep. And when I run my intradermal suture patterns, I like to go vertically. So I go across my incision. So superficial to deep. Come out at that corner. And then deep to superficial on the other side. And I advance in the underneath the skin, and then I can't come straight across at the skin margin. So deep to superficial, come out at that skin corner, and then superficial to deep, going straight across our incision. And then advance on the underpass, coming out right at that skin margin right there. And I think that looks really nice. The alternative is that you can go horizontally, so parallel to your incision. Dr. Chirag, Dave, can you please mute your microphone? Everybody, please make sure that you've muted your microphones because it's going to mess up the video for everybody later on. Is it okay now? Sharat, you're not muted.
Mahesh Kumar.
Thank you.
Good morning.
Chirag, you're not muted.
Hey.
All right, so
Sure.
Chirag, you need to mute your microphone. Chirag, I'm going to kick you off the live stream if you don't mute your microphone, because you're messing up the video for everybody else. Thank you. So we're going horizontally. And that looks okay. You can get quite a squiggly incision if you do it that way. My preference, again, is to go vertically. So this is how most people do it. Sharat, you need to mute your microphone. Okay, so now the way that I like to do it is to go across, superficial to deep. Like that, and then deep to superficial. I think it makes a neater incision. It is a little bit slower because you only advance on one of your passes, but I think it looks nicer. Okay, now when we want to bury our knot at the end of our incision, the first thing we want to do is go superficial to deep. So we have one end of the suture deep. Okay, so we've got one end deep, and then we want to go deep to superficial. And then superficial to deep, so that all of our ends are now deep in the tissue. So when we pull this tight, so we've got all of our ends deep. Now when we tie this, we can either tie it with a regular knot like this, and then I'll cut my loop. My knot is still sticking out a little bit, and then I'm going to go from the center of my incision. Varan, can you please mute your microphone? And then come out. Varan, please mute your microphone. And then we're going to come out to the side, and you can see that it's going to pull our knot underneath really nicely. Okay, now I'll show you the alternative to the regular knot that we can do. So again, I'm going deep to superficial to start it. Superficial to deep. Pull my knot tight. Cut that off. And then when we make our first bite, we want to make sure that we go deep to superficial. And that's going to finish burying the knot. So now our knot is nice and buried. And I'll do a couple of passes and I'll show you the Aberdeen knot, which is the next trick on the schedule. So we've got an end that's deep here. So now I'm going to go deep to superficial. And then superficial to deep. So all my ends are deep now. And now I've got this loop here. Now the other way to do it is to, let's see if I can, I'll zoom out so you can see. So I've got that loop here, and then I'm going to pull my long tag through the loop and pull that loop tight. Then I'll do it again. And you do this about 5 times. And then on the last one, I'm going to pull that suture through and then pull it tight. And we've got a really nice tight knot there. And then to bury that knot, we're going to pass our needle from deep to superficial out to the side like this. And then when we pull it, it's going to bury that knot really nicely. Okay, now any questions? I've got a comment. Sorry, I don't know if you can demonstrate a Z-plasty and artificial skin. I doubt it. I can try. Let's see how I go later on. Okay, so regarding tendon repairs, the suture material that we use is something non-absorbable and monofilament. So typically I would use Proline. You can also use a multi-filament. Like Rasika, can you please mute your microphone? Thank you. So you can use a multi-filament as well as a monofilament. All right, so now I'm going to show you the next trick, which seems to be the most popular thing, is how to suture using, so these are not Olsen-Hager needle drivers. These are Mayo-Hager needle drivers, and they're definitely my preference. I I really hate Olsen-Hager's because the action, because of the presence of the scissors, the action is really, really poor. And so the way that you can suture and cut your own suture, the first thing that you're going to do, you're going to hold your scissors like you normally would with your ring finger, and then we're going to flip our scissors back like this. Okay, you can flip them forward, flip them back. All right, so I flip it back like this, and then I'm going to grab my needle drivers like I normally do. So I'll take a bite across here. Tie my suture. And then what I'm going to do is I'm going to clip down on my needle driver and pass it to my other hand. So now I've got both ends of the suture tight, and then I'll flip my scissors, cut my suture, flip them back. So I'll show you that again. So taking a bite, tie my knot. And I always do 5 throws. Clamp down on my needle driver, hand it to my other hand, flip my scissors out, cut the suture. And if it's any indicator about the handleability and use of Olsen-Hager's, you'll find that no human surgeons use Olsen-Hager's. Everybody uses the conventional Mayo-Hager needle drivers. And you could say that it's because they have assistants, but not all of them have assistants to cut their suture. And I've learned this technique so that I don't need any assistant to cut my suture. Let me zoom in a little bit more so you can see what I'm doing at the level of the suture itself. I'll just open some more suture material. All right, so take a bite like you normally do. Pull it tight. Make my knot. I'm leaving it a little loose because it's skin. 5 throws. Click, pass it to my other hand, flip the scissors, cut, flip the scissors back. Okay, any questions about that? So I've just got my list here. I'm just going to check off the ones that I've done already. So I've done my slip knot, I've done my locking loop, I've buried my knot, I've done my Aberdeen, I've done the scissor flip. I've done my horizontal and vertical intradermal suture patterns. I've got a few things to go. All right, so let's say we've put in a tube of some type, either a drain or a urinary catheter or something like that. So I've put my drain in wherever, whatever body orifice or hole or whatever it's sitting in. And then I'm going to do either a purse string around the opening or just a cruciate pattern. Why don't I do a purse string for now? So the purse string is going to help prevent leakage. So I take my first bite. Actually, now what you want to do is you want to leave some long tags on both ends. I'm coming around the opening. Like this. So this is a purse string. Because funnily enough, it looks like a purse string. All right, and then when we tie this, I'll do hand ties here. So I'm tying this, I'm going to pull it tight, and you can see that it cinches down around the suture. Now I'm going to do a few extra hand ties. When I do hand ties, let me zoom out a little bit. When you do hand ties, you basically have 2 different throws or 2 different patterns. So when the end of the suture is coming down toward you, you grasp it with your index finger and your thumb, and we're going to lay the other suture on top, and then go through and grab with our middle finger. Maybe not. So go through and grab with our middle finger and pull it through. And then when the tag, the short end, is pointing away from you, we're going to grab the suture with your thumb and your middle finger and make an X with your index finger like this. And then we're going to pull the suture through our loop. Sorry, it's, as I'm demonstrating it, it's a little bit harder to do. So I'm going to make that pattern like this with my index finger in the middle, make an X, and then pull it through with my index finger. So middle finger, index finger. And you can get quite quick at it. You can practice on your shoelaces. Okay, now that's obviously much, much longer, many more throws than we would normally do. Now, if we want to secure this tube, what we'll do is we'll pass the suture around the tube in both directions like this, and then I'm going to do 2 throws. Sorry about this. 2 throws like this. Pass it around again. Two throws. Pass it around again. 2 throws. And I usually do this about 5 times. So I get a nice long trail. It is easier to do this with an assistant. Okay, and on that last one, I'll do my 4 or 5 throws. And I'll cut this short. And you can see that it's very secure. Let me zoom back out a little bit. You can see my nice little square knots. When you look at the suture, you can see my nice little square knots. So we'll come back out and you can see that that's very secure. Now, most people think that once you've done the finger snare, you can't adjust your tube at all. But in fact, all you have to do is collapse your knots down like this. So collapse them down. Then you can adjust your tube, pull it in or out, whatever you'd like. And then when you want to lock it in place, you spread the knots back out again, and then it's locked again. So that's a really good trick. So collapse it down, then you can move the tube in or out. So you can see I'm moving it quite far, or I can push it back in, and then when you want to lock it, you just spread the knots out again, and it's locked in place. There's a comment from Helena about how to hold on to the suture if it's too long. Let me just see if I've got some extra suture material here. Hold on. Get another pack of Turoproline. You guys are expensive. All right, so when you have suture that's too long, I'll zoom out again. So say I've taken a bite like this. It's not muted. So when you've got your tag like this, and my end is really long, the way that I do it is I wrap it around my fingers like this. And then when I get to the end, I pinch it between my thumb and my forefinger. So now all I've got is this little tag right here. And then I can tie my knot. So I'll cut that and show you again. Can you guys all please check to make sure that you are muted? I'll try to mute everybody again. Somebody's picture is coming on. Sanmat, can you please mute yourself or I'll have to take you off the live stream because you're wrecking the video for everybody else who's watching. Okay, so I'll show you again how I do that. I take a big bite here, pull that through, and this end is going to be really long. So even as you're pulling it through, you can wrap it around your finger like this until you get to the point that you're happy, and then grab it between your index finger and your thumb. Tie your knots. Click onto your needle driver, pass it over to your other hand. So both ends are tight. Cut. And then you can release the suture again. Does that answer your question? All right, so the next suture pattern that I'm going to show you is a Cushing suture pattern. Let me just get this catheter out of the way. Pull that out. I'll just cut my scalpel. I'll just cut my purse string. And I'll get rid of these skin sutures actually so that it's easier for me to show you a Cushing. Now the three suture patterns that we use on organs that have a lumen are the Cushing, Cornell, and Lambert. And you can remember that Lambert and Cornell both have L's in them, so they are the ones that go into the lumen. And Cushing doesn't have an L, so it doesn't go into the lumen. Now the way you do a Cushing suture pattern is you start as per normal. See, I'm wrapping around my fingers. Do my normal first bite, my first knot. Click, pass it over to my other hand, and then I'm just going to cut my short end here. Let me zoom in a little bit so you can see what I'm doing. All right, so then I'm going to grab my needle drivers and I'm going to pass my needle parallel to the incision, but I'm not going into the lumen. And all of these suture patterns, Cushing, Cornell, and Lambert, are inverting suture patterns. So it doesn't work very well with the fake skin. But I'm just going parallel to the incision. Oops. And then the idea is that when you pull it tight, it's going to invert the tissue layers. And it works better on real tissue, but you can see what we're doing there. Now with let me just cut this one out. Get rid of these guys. The difference between a Cushing and a Cornell is the Cornell looks exactly like a Cushing except it goes into the lumen. So I'll start another one and I'll show you a Lambert. So we do our normal first knot, slip knot. And when you get used to it, the slip knot is just so controlled with how much tension you put on it. Now with the Lambert, what we're going to do is we're going to take a bite on one side, in and out. And then take a bite on the other side, in and out. And these do go into the lumen. And then when we pull this tight, it is also going to invert the tissue. You can see how that's going. It works much better with real tissue. Okay, now the way that I would close a urinary bladder, there was a question about that. I would close it, usually what I do is a simple continuous pattern in the mucosa, and then I usually do a Cushing or Cornell in the muscularis and mucosa and serosa. Okay, any questions about that? There's a comment to zoom the camera. When putting a chest drain in surgery or even without surgery, thoracic effusion, chylothorax, any tricks, special tips to make it leak proof? So if you're placing a chest tube, you want to tunnel the tube subcutaneously before you drop into the body cavity in probably about 4 or 5 centimeters. And then once your tube is tunneled and then drops in, so I'm tunneling it along here. Okay, so you can see my tube sitting right there. I'll just draw where the tube is. The tube is right there. What I do then is do a couple of cruciate sutures through the skin and around the tube. So I would go around the tube like this. Like that, encircling the tube. And then you'd pull that fairly snug, so it doesn't matter that it's encircling skin. And watch how I turn it into a slip knot by pulling on one side. And then I pull just on that one end and then pull it apart to lock it. And you can see that I've nicely constricted that sub-Q and skin around the tube. And that's going to make it not leak air or fluid in or out. Okay, question about when so you probably, there's a question or a comment about suture, do you really need 2-layer closure when you suture the urinary bladder? The answer is probably not, but I like to have that extra security. I have had urinary bladder leak before, and so I like to use a simple continuous in the mucosa and submucosa, and then I'll use a Cornell or a Cushing on the muscularis and serosa. Question about suturing the uterus. What's your way of suturing? First layer simple continuous and second layer Cornell. Probably similar. Probably similar pattern, yeah, that I'd use in the bladder. And Dr. Ahmed has a question. Can I perform that? What are you asking me to perform? Is it the closure on the urinary bladder? Let me know. Let me just make sure I haven't. So I don't know that I can do that here. Let me just say, I just don't know that, because I don't have 2 layers here, I can't really demonstrate it. But basically the deep layer is going to be simple continuous in the mucosa and submucosa, and then the superficial layer is going to be a Cornell or a Cushing like I showed you before. When I close muscles like a perineal hernia, so when I'm closing a perineal hernia, I am hopefully closing the tendinous insertion of the internal arbitrator muscle up to the external anal sphincter and the coccygeus muscle, and I'm going to use a simple interrupted pre-placed suture pattern. So what that means is that I pre-place my sutures, leave them long, and hemostat them, pre-place, hemostat them, all of my sutures, and then I'll tie them individually with hand ties. Any other questions or comments? Let me see how I'm going on my list. I think I've done everything on my list that I intended to do. Another thing that is handy is when we're running a simple continuous suture pattern. So I'll do my first bite here, and I'll tie my knot, and I'll show you a little trick to speed up your closure. Oh, another trick that's really handy is that if you shake like I do, what I'll do is if I'm doing something really delicate, I'll grab on to the needle drivers. Let me zoom back out. I'll grab onto my needle drivers with my other hand. So, and that really, really steadies it. So you can see there's no shaking there at all. Whereas if I'm using one hand, I'm shaking a little bit. So I grab on with the other hand and then use both of them to pass. And then when I grab my needle, I grab it with my thumb forcep and re-grab with my needle holder straight away and then pull it tight. Put the needle through, grab it with my thumb forcep, re-grab, pull it tight. And so that saves you an extra step and really speeds up your suturing. See how quick that is? And that's how I can suture so quickly. Now, what do I do if I've gotten down to here and I don't have enough suture to close with? There's another trick that you can do. Let me just pull this off to the side. So what you can do is, if you don't have enough suture, you can put a loop of another piece of suture through that loop. Okay, so now, can you guys see that? I've got a loop there, and then I can use that to tie to. So I'll cut I need to sharpen these scissors. All right, so I've got my loop through the second to the last bite. So an extra piece of suture, and then I can take this and tie to that and see how it pulls really tight nicely. That's one that I hadn't shown the last time. So then you do your normal 5 throws and cut it off, and it's just as secure. Okay, did everybody get that? There's a question about when you're suturing the abdomen, do you prefer simple continuous or interrupted? I do a simple continuous. As long as I'm confident in my knots at both ends, I'm very happy to do simple continuous. Reports of suture into the bladder lumen can lead to calculary cystitis. That's a really good point. And so I tend to use, in hindsight, I tend to use a Cushing rather than a Connell. Cushing, which is going to avoid suture material in the lumen. The intradermal sutures, I don't know if you joined us late, but I went through intradermal sutures earlier. And so just review those, and then if you still have questions, let me know. Any other questions or comments anywhere? That's great, Helena. I'm glad that you are enjoying it and getting a lot out of it. Do you want me to show you that technique with the loop again? It might not have been clear. So let me just pull out all of these sutures and I'll demonstrate that one more time. That loop trick, I reckon, is one of the coolest tricks I've learned. My dad taught me that. My dad is a retired cardiovascular surgeon. Whoops, I hit the camera with my chair. See if I've got any more suture here. I've got another pack of Proline. So I'll show you that loop trick one more time. So you're going along here. And you're thinking you're going to get to the end with this one piece of suture. And then you get to the end and realize, shoot, I don't have enough to close to, or to close with. I'm trying to make it really challenging for myself. Okay, so now I've got this short little tag sitting here. So I leave this loop long, like this. I might have made it too hard for myself. We'll see if I can get away with it. And then cut the needle off. And then we're going to pass another piece of suture through that loop, like that. And then we're going to close, we're going to use that loop to close with, or to tie with. So I just have my knot here. How good is that? Okay, and secure as anything. All right, any questions? So let's see, do you plan to give us a lesson like this on a different topic? Yes, I do, I just am not sure what it would be. Let's see. When you have, I'm just going back. Locking loop suture pattern for any other purpose. Really, the locking loop is only for tendon repairs. When you have a deep defect and you don't want to put synthetic mesh, can we suture one side of muscle to cover to defect of the other side and similarly overlapping other side of muscle in a similar pattern to help provide extra support rather than suturing both layers together? So basically, I think that you're saying that you're creating your own mesh. So you're almost going to weave suture across it, and you definitely can do that. For eyelid resections, I'm not an ophthalmologist, and so I don't do a lot of eyelid repairs. There is a special pattern that people do, and I'm not sure that I could replicate it. So maybe next time somebody who's experienced in that can show us. So if you have ideas for other lessons that you'd like this, I'm happy to do them. Just send me a message through or whatever and let me know. Is it necessary to bury the first and last knot in the Cushing pattern in the bladder? No, it's not. So for intestinal resection and anastomosis, the way that I do those is if I have the end of the intestine here, like this, the way that I do it is that I would put one suture here on the mesenteric border and tie the knot, leave that tag long, put another knot on the anti-mesenteric border, tie it and leave it long, and then I'm going to run a simple continuous pattern from one side to the other, and then on the deep side I'm going to do the same thing. So those two stay sutures are going to help keep the intestine under tension. So I'll show you what it looks like. When you're suturing, the intestine is stretched out like this, and then you're just running a simple continuous suture pattern from one side to the other. So that's how I do it, and I typically, I I typically do a simple continuous on that. And you want to make sure that you're about 2 to 3 millimeters apart and 2 to 3 millimeters into the tissue with each of your bites. When I'm closing the bladder, I don't use an omental flap. When I'm closing the intestine, I do. Somebody's asking about an anesthesia. Toot, I will see if, I'm not an anesthesiologist, but I will see if I can find somebody to do that. Let me just make a note here about, I have a great friend who's an anesthesiologist who would love to do a toot for you guys, I'm sure. I'm just trying to find a piece of paper to write it down. All right, let me just see. And so I will post this recording on YouTube. So just go to our YouTube channel, which is Southpaws Vet. And that recording should be up either later on this afternoon or tomorrow. So if there aren't any other questions, I'm going to go ahead and wrap it up. I'll stick around for about 3 minutes or so. Get my blades and needles out of the way so that I don't stick myself when I clean up. And if there are any other questions, please let me know. I'll stick around for a couple of minutes. So I'll just clean up my mess here on my desk. So this is this fake skin that I have that's quite expensive, but it's really good for suturing. It has an intradermal and a subcutaneous layer. I'll take the box out and I'll show you the front of the box in case you decide that you want to buy some. It is expensive. So it's called Real Suture Suture Pad Light Skin. So it comes in light skin and dark skin. And 3-layer. I'll show you what the underside looks like. So you've got this weird sticky stuff. 3 layers. So there's a question about skin flaps. I'm happy to do a skin flap. We're probably going to do it on VetDojo because it's such an involved topic. So that'll probably be a paid module on VetDojo, although I can maybe do some tips and tricks at some point. That's not the complete module. Let's see. For intestinal anastomosis, how deep should we go? I go all the way into the lumen when I'm doing intestinal surgery. Let me just switch this back to my face. Here we go. All right, so just looking to see if there are any other questions. And that's such a pleasure, Piyush. You're always such a loyal fan and participant, so I'm very happy to do it. And if there are no more questions, I'll go ahead and wrap it up. So thank you very much for watching. I don't have any more surgery this week. I'm off tomorrow, but then I'll start up again on Monday, and hopefully I'll be able to live stream some stuff then. So again, really enjoyed everybody's great questions, and we will go ahead and wrap it up now.